Morning. We'll discuss on palliative care. In palliative care, you should know what is palliative care, why is there the need of palliative care, who are the personnels involved in giving palliative care, where we have to give palliative care, when we have to give palliative care, and how we can give palliative care. First, we will see what is palliative care. Palliative care is defined as the active total care of patients whose disease is not responding to curative treatment. It is an approach improving the quality of life of patients and their families facing problems associated with life-threatening illness. Let's see the difference between curative care and palliative care. In palliative care, the treatment will be symptom driver, but in curative care, it is disease driver. In palliative care, quality and comfort of patient has more importance. But in curative care, curing the disease is foremost important. In palliative care, patient is in charge, where in curative care, doctor is in charge. Disease process is secondary to person in palliative care, where in curative care, disease process is primary. In palliative care, we have many choices, but in curative care, we have only few choices. Coming to the goals of palliative care, there are 8 goals. Starting with the integrate the psychological and spiritual aspect of patient care, offer a support system to help patients life as active as possible, offers a support system to help the family cope, uses a team approach to address the needs of patients and their families, enhance quality of life, intend neither to hasten nor postpone death, affirms life and regards dying as a normal process, providing relief from pain, distress, and other symptoms. So, why is we have to give palliative care? Most of the new age diseases like cancer, diabetes, chronic lung diseases, other communicable diseases are leading to palliative care. These are due to physical inactivity, alcohol abuse, usage of tobacco, and unhealthy diet. About 8 lakh new cases of cancer in India every day is coming, and we have to provide palliative care for all those people. 1.6 million people suffer from cancer pain. 53% of death in India is due to cancer. The long-term care of such patients are a major healthcare issue. About 70% of people aged 60 plus will need some type of long-term care service during their lifetime, where we can give palliative care. We can give palliative care in hospital as consultation model, outpatient model, and inpatient model, and also in community-based or home-based palliative care as supportive care, hospice care, and end-of-life care. Then, who can give palliative care? Palliative care can be provided by primary palliative care providers, specialist palliative care providers, and related sectors. So, the team should include a, a person from physical medicine, from psychological field, spiritual field, and also from social field. Coming to Indian scenario, Shanti Avedhan Sadan, the first modern hospice in India, was established in 1986 in Mumbai by Professor Dr. L.J. D'Souza. In 1975, Government of India initiated a national cancer control program with a provision of palliative care. Indian Association of Palliative Care, the umbrella organization, was registered as national organization in 1994. In April 2008, Kerala became the first state in India to announce a palliative care policy. India does not have a national policy on palliative care. Currently, 138 organizations are providing palliative care service across 16 states. The services are usually concentrated in large cities and regional cancer centers, with the exception of Kerala. Only, only 3% of India's population is accessible, with Kerala providing two-thirds of India's palliative care service. In Kerala, network has more than 60 units covering a population of greater than 12 million and is one of the largest networks in the world. Calicut model is known as WHO demonstration project. WHO recommended three foundation measures for developing palliative care. One is governmental policy, then educational, training and research, and drug availability. Coming to the obstacles, the obstacles for palliative care includes population density, poverty, diversity, restrictive policies, workforce development at base level, limited national palliative care policy, and lack of institutional interest in palliative care. Coming to the communication skills, good and effective communication is not optional but mandatory. Communication can never be neutral. It is either effective or ineffective. We should greet and make the patient sit while communicating. We should encourage them to talk. We should maintain eye contact. We should tolerate brief silence. We should avoid unnecessary interruptions. We should show them we are listening. We should summarize and prioritize the agenda. And we should show empathy and give realistic hope. Coming to communication techniques, we should always ask open questions, being empathetic, be sensitive while telling the truth, attempting to balance hope and truth, maintaining confidentiality and avoid unhealthy curiosity, partnership between doctor and patient. Coming to breaking bad news, strategy for breaking bad news to acquire the skill tailored to the need of individual concern, reduce the impact of the news, facilitate understanding and acceptance. So, breaking bad news will well and you will always be remembered. Breaking bad news badly and you will never be forgotten. This is a protocol for breaking bad news. It is called SPICE strategy, in which S stands for setting, P stands for patient's perception, I stands for invitation, K stands for knowledge, E stands for empathy, and S stands for summary or strategy. Why should patient be told about their disease? The act of shielding information from the patient or family is called as delusion. Not wanting to know the diagnosis is a form of denial. And telling the prognosis, it is the most important part in palliative care, of which we used to hear the question, how long I will live? And we should answer it very sensibly. Coming to nutrition in palliative care, the importance of nutrition ensure overall well-being and quality of life, maintaining a strong immune system and reduce the risk of infection, cope with demands of illness and treatment, increase the wound healing, and tissue repair. Issues that can happen, loss of appetite may be due to anxiety or depression, and also due to medications. Weight loss is one of the important our major issue that we are facing. Not feeling hungry and not eating much isn't the only cause for weight loss, and we should optimize nutrition. High protein meal and snack should be added. High calorie ingredients to meal, drinks, desserts, and snacks to boost energy without increasing the oil. And we should also include variety of food items. It is because the patient who is under the treatment will have only a less amount of food. So in that less amount of food, we have to put more nutritious items. When it comes to palliative care, dentistry, the role of dental surgeon in palliative care. The importance of dental care is often overlooked due to the omission of dentist as a member of palliative care team. Come to the definition, palliative care dentistry is defined as the study and management of patients with active progress or advanced disease in whom the oral cavity has been compromised either by the disease directly or by its treatment. Good oral hygiene is the fundamental for oral integrity. 89% of those in terminal ill with cancer will complain of at least one oral symptom. So these are the symptoms which can commonly seen in palliative care. It causes physical implication and psychological effects. Diagnosis and management of oral lesion. Dental surgeons plays a pivotal role in diagnosis, treatment, and management of oral disease in patients under palliative care. Post-treatment, post-radiation stenonecrosis, avoidance of trauma, removal of bone sequestration, use of antibiotics, hyperbaric oxygen therapy. After radiotherapy, surgery, and chemotherapy, the patients may experience difficulty in speech, swallowing, breathing, and aesthetics. Rehabilitation of the defects occurring after surgery as far as possible will help the patient to lead a better life. Come to management of pain. So it is an important part in palliative care. The relief or reduction in severity of pain or associated discomfort will be the greatest help that can be offered to a terminally ill patient. Into the definition of pain, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Pain is what the patient says it hurts. It can be physical or emotional or social. So, taking pain history is most important so that we have to get a good grasp of. We should give open questions. Patient doing the most of the talking. Watch for the clues regarding the pain. Avoid immediate conclusions. And assessment of pain questions includes the onset, present since, frequency, progress, and other following points should be to the management. Aim of the treatment should be always to improve the quality of life and not just pain relief. Freedom from pain is a human right by WHO 1986, which can be used the NSAIDs and opioid analgesics. This is the WHO analgesic ladder for palliative care. It includes medium to moderate pain, moderate to severe pain, and severe pain. For medium to moderate pain, we can give non-opioids and anti-inflammatory drugs or paracetamols. For moderate to severe pain, mild opioids with or without non-opioids can be given. For severe pain, strong opioids with or without non-opioids can be given. Thank you. Thank you very much.